Continuing Mobile Education for Emergency Medical Services Providers. This is Evaluating the Older Adult, Episode 3, The Fallen Older Adult. At the end of this episode, you should be able to describe common injury patterns seen with the older adult after a fall, learn some obstacles in evaluating the older adult who has fallen, and review common causes and consequences for falls in older adults.
One patient that was difficult to assess who was a fall victim was an elderly female patient who we went to and had fallen down in her kitchen. When we arrived, we noticed that her colostomy bag had burst open and there was dried feces covering her body and her floor and on the walls. And so we knew she had been down for some time because that feces was all dry. She didn't know how long she had been down. So in a patient like that, we're concerned about a lot of things that are sort of environmental or caused by the fall or being down that long, such as hypothermia or hypoglycemia or rhabdomyolysis or other things that could have been, or pressure ulcers from laying on the floor that long. So it brings up a whole gamut of other medical problems that might not have been caused by the initial fall, but could have been caused as a result of sitting on the floor for 1 day, 2 days, who knows, because she lived by herself.
Falls in older adults are very common, and they're considered what you would describe as a multifactorial event, meaning that there's lots of different factors which can contribute to older adults falling. One way to categorize the things that put older adults at risk for falls are intrinsic factors, so those things within the person themselves. We often think of medical conditions. Things like low blood pressure states or orthostatic hypotension. Things like sensory impairment, visual or hearing difficulties can contribute to falls. A person's muscular development, so weakness and how that relates to frailty overall. All of those things can contribute to falls. Then you can think of the extrinsic things, so the things that are around a person or interacting with a person. I think one of the biggest things in that category is medications. There's a variety of different medications that can cause or contribute to falls in older adults. Polypharmacy or multiple medications kind of in combination in older adults can also contribute to falls. And the last kind of a subgroup of factors for falls are environmental factors. So things like how the household is set up. Are there throw rugs that a person could slip on? Is the lighting appropriate so that you can see changes in step height or surface environment? Is the footwear appropriate for the surface that a person's walking on? Are there grab bars and appropriate assistive devices to allow people to have maximal balance?
When considering what caused a fall, recall that falls can be caused by multiple factors, including medical conditions, extrinsic factors such as medications, and environmental factors such as low lighting, throw rugs, poor footwear, and lack of assistive devices.
Some of the injuries that an elderly person can sustain from a fall include injuries to the head, such as a subdural hematoma, or epidural hematoma, or subarachnoid hemorrhage. All of these can result from either the fall or the sudden deceleration of the head, and then sometimes can present at a later time. Other injuries include injuries to the skeletal system, fractures of the arms, also commonly seen are fractures of the hip. Skin abrasions and lacerations can be particularly bad in the elderly if they have thin skin or if they're on blood thinners. And other preceding things to the fall, such as infections, pneumonia, urinary tract infections, can all be seen that could potentially cause the injuries themselves and need to be further evaluated.
So most falls result in minor injuries, things like scrapes and bruises. But about 5 to 10% of falls will actually result in major injuries. This is part of what contributes to falls being the number 5 leading cause of death in older adults. Falls can really create some very medically serious events. Those types of injuries are usually things like significant fractures like hip fractures or other large bone fractures. They can create head trauma as well, things like subdural hematomas, and can also contribute to significant lacerations, which can cause blood loss. Falls in and of themselves can be a very serious event, as they contribute to declines in the functional performance of older adults too. So that after a person has fallen, we often see that they have changes in their usual daily activities, changes in how much they go out and about, and these things can create a very important cycle of people avoiding activities, becoming more frail, and then having more risk of falls and the injuries that result from them.
Approximately 10% of falls lead to major injuries, including fractures, especially to the arm and hip, and intracerebral hemorrhages. Others sustain minor injuries, such as lacerations and contusions.
I think the toughest part of evaluating a fall in an older adult is determining whether the fall caused a medical or trauma-related problem, or did a medical problem cause the fall. And that's always sort of a chicken or the egg come first problem, because we don't necessarily know. Another one is deciding whether to backboard a patient or not. Frequently, these patients might not remember what happened. They might have slid down to the floor, but they might have hit their head. And so that determination on whether to use a backboard or not is particularly tough in an old person, because you're thinking about, well, they have severe kyphosis, or they're going to be sitting on this hard board in the ED and they might get pressure sores. So that's a difficult decision to make.
I think the biggest obstacle in evaluating falls in older adults is that people are reluctant to report that they've fallen. There's, I think, often a disconnect between people identifying falls as a medical event, and so they don't commonly tell people if they've fallen unless there's been a significant injury. Similarly, medical providers often don't ask older adults about falls routinely, and in doing so, we miss an opportunity to intervene for people who've had falls but not yet had injuries from falls, because that initial intervention into falls allows us an opportunity to modify some of the risk factors that a person might have for falls, to provide a comprehensive assessment for factors that person might have that puts them at risk for falls, and to develop with the patient a care plan to really maximize their function and minimize the chances that they'll have a fall that could result in a significant injury. So I think one of the big things that we can do is engage in the conversation, really ask about falls, ask about balance issues, so that we can intervene early.
Some obstacles to evaluating and treating a fall victim include that patients may not report that they've fallen. We have to wonder, did a medical problem lead to the fall, and we have to consider if the patient should be backboarded or not for transportation to the receiving facility.
Falls can affect the older adult in the long term on several different levels. The first of which is can result in a loss of their independence, especially if they were living alone or with another elderly family member that was their primary caregiver. If they have a loss of function, such as a fracture or or a stroke, it's likely that they won't be able to return home immediately, or if at all.
Older adults are very affected by falls. I think people commonly think of the injuries that people have from falls, and acutely that's a big effect of falls. But falls can also contribute to changes in activity level, so that people who have fallen are much more likely to restrict where they go and restrict what they do. This can contribute to development of frailty, lower muscle states, can also contribute to social isolation, which can impair the quality of life of an older adult. And falls can create a fear of falling, which in and of itself is identified to be a risk factor for more falls, and can in and of itself have a lot of psychosocial impacts on older adults.
Some long-term consequences of falls include debilitating injuries, changes in activity level, and social isolation, which can lead to its own set of psychosocial problems.
I think it's important for EMS and fire departments to help reduce the number of falls that elderly people sustain by doing little things like when you bring them home or go pick them up, if you can, make sure that the throw rugs are not all over their house, or make sure lamp cords are away. If they have light bulbs that need to be changed, maybe change a light bulb so that they can see what they're doing. Another really big one is the nurses and doctors in the hospital frequently aren't seeing the environment they're coming from. So we have a unique advantage in seeing exactly what their environment's like, and I think we're in a unique position to make some recommendations in terms of if that situation is appropriate for them. So getting social services involved in some of these people's lives and getting them a more appropriate placement.
EMS is actually well suited to help older adults with their fall risk. I think one of the first things they can do is ask, engage in that conversation with an older adult about whether they've fallen recently, and if so, what the nature of the fall was. That starts a conversation that puts in both the medical providers but also the patient and their families' minds the importance of really discussing falls. The second thing that I think really is important for EMS providers is that they have an opportunity that most healthcare providers don't, to see where a person lives and how they live. And that glimpse into the environment can really provide wonderful opportunities to diminish fall risk. So seeing how the home is structured, how the thoroughfares in the home are, and whether they would contribute to difficulty ambulating in that environment. Looking to see if the lighting is maximized, if there are throw rugs on the floors, if there are railings places where railings or grab bars might aid an older adult in their balance. I think it's often often not given enough value that simple advice from well-respected providers like emergency medical service providers to look at those types of environmental issues, get rid of the throw rugs, consider putting up a grab bar, is actually well heeded by older adults and may create an environment that's much safer for people. The other things that I think EMS providers see are things like footwear. You know, I know from working in the hospital, by the time I get my patients, usually the shoes are off, so I don't have a sense of things that may seem small, but that certainly could contribute to falls, whether people are wearing appropriate shoes, whether there were shoes on at all when they fell. Again, small things, but things that really can contribute to the stability of an older adult. Medications, I think, you know, people who are in the home have the opportunity to see the different pill bottles and polypharmacy that older adults are taking, and have an opportunity to both relay that to other medical providers, the primary care provider, the emergency department physician, but also start that conversation with families and patients about the risks of certain medications.
EMS can help prevent falls by talking to the patient about falls and the risk related to them, telling patient how they can improve their fall risk, tell the physician what the home environment is like, and get elder services involved if the patient appears to need help. After finishing this episode, you should know the common injury patterns seen with the older adult after a fall, learn some obstacles to evaluating the older adult who has fallen, and review some common causes and consequences for falls in older adults.